So again, I have nothing to disclose. I'm going to talk a little bit, the full gamut of critical care. The first one is on therapeutic hyperthermia and targeted temperature management for 33 degrees versus 36 after cardiac arrest, published in the New England Journal earlier this year. And as we all know, therapeutic hypothermia is part of post-resuscitation care following out of hospital VFib cardiac arrest. Most protocols are 24 hours for therapeutic hypothermia at 33 degrees. And with the advent of post-resuscitation care and therapeutic hypothermia, there's about a 60% survival. And so in this study, 950 patients were randomized either to 33 degrees or 36 degrees for 24 hours. When you look at the outcomes, primary outcome was all-cause mortality. This was similar between both groups. When they looked at 6-month follow-up, mortality was similar, and neurologic outcomes were also similar. So the new standard of care for those who take care of mostly medical critical care patients is now the 36 degrees, and seems to be making a significant, or most centers are now doing this. Does this apply to trauma? And so I gave this talk, Hypothermia After Cardiac Arrest, at St. Joe's a couple weeks ago, and I can't find that presentation, but my question was, I was trying to decide, does this benefit the trauma patient? And when you look at the data, the Cool Kids study and then a Korean study, in fact, therapeutic hypothermia worsened outcomes in patients with TBI. So you can't equate this literature and think that you can apply it to the traumatic brain injury patient. So just keep that in mind. This is a study, a randomized trial of protocol-based care for early septic shock, published earlier in the New England Journal this past year. We're all very familiar with the Manny Rivers data and early goal-directed therapy improving outcomes for sepsis and septic shock. This study and the one to follow challenged that notion, although I think they didn't know they didn't realize what they were about to do was kind of debunk some of this. But they randomized 1,341 patients to protocol-based early goal-directed therapy. And if you can see the red circle, the protocol-based therapy, these patients all got the Precept catheter or the continuous SCVO2 catheter with continuous oximetry, versus the protocol-based standard therapy. They didn't have to have this continuous port, versus standard usual care, which was non-standardized, non-protocolized. And these patients were randomized into 3 groups required. Each group had 6 hours of post-resuscitation care, post-care. When they finally drilled down into the primary outcome, there was no difference in 90-day mortality or 1-year mortality. Some of the discussion for the paper, however, said that while a protocol-based therapy may not improve outcomes, what has been shown over the last couple years is that we're identifying these patients early, we're treating them earlier, we're volume resuscitating them adequately. And so, but this paper sheds the light on whether true invasive measurements is what is needed to improve outcomes. And in fact, this paper says no. This next one, also published in the New England Journal. You'll see this is a New England Journal show. There's a lot published this year that was very good. And these are all randomized studies, except one that I'm going to show you. But the ARISE investigators looked at goal-directed resuscitation for early septic shock. And they enrolled 1,600 patients from Australia and New Zealand. First group, 800 patients, early goal-directed therapy, and the other usual care, again, non-protocolized, non-standardized. The bedside team had the option to care for them as they would. The protocolized group did have an SCVO2 catheter and arterial catheters as part of their intervention. Both groups had to follow the resuscitation algorithm or resuscitation for 6 hours. And primary outcome, again, for all-cause mortality at 28 days was not improved, nor was it at 90 days, in-hospital mortality and hospital length of stay. And so these two papers really challenge the notion of protocolizing early goal-directed therapy. And so it shouldn't change your standard of care, but it may not, you may not need to rely on these fancy catheters to get you the information that you need to adequately take care of these patients. So two very well done studies. For Dr. O'Neill in the group, and I wasn't even going to mention this study today, but then with Dr. Davis's biases yesterday, and I thought, well, let's just go ahead and throw this in here. And for those of you that work at Chandler, you know I can't even spell the word. So albumin replacement in patients with severe sepsis or septic shock. Long time controversy, not a lot of good data to support its use, but we all know that the indications are for, or potential indications are to increase oncotic pressure, increase intravascular volume. There may be less fluid given, maybe less vasopressor support. And so 1,818 patients were randomized to receive 20% albumin to a set goal of an albumin of 30 grams per liter or 3 grams per deciliter, plus crystalloid or crystalloid alone. They didn't specify what type of crystalloid. I spent hours looking for it and couldn't find it. The primary outcome was death at 28 days from any cause. And in essence, for both the severe sepsis and septic shock group, when you look at them together, mortality at 28 days and 90 days was similar, as were the secondary outcomes. When you look at post hoc analysis, which included a lot of patients, 1,100 patients, but that wasn't the primary outcome, so the post hoc is doesn't have as rigorous study, but found in patients with septic shock actually lowered their mortality at 90 days in the albumin group. And so the question arises is, does the severe or the septic shock group actually benefit from albumin? Again, not a primary outcome, underpowered. Anyway, so there's still not a lot of good data out there. It's more so against the use of albumin. I'm sure at some point we'll find a study where it does show some benefit. But for now, that's where it stands. This is a study that was also published actually this past month, looking at lower versus higher hemoglobin thresholds for transfusions in septic shock. And we're all very painfully aware of the surviving sepsis guidelines, but in essence what is recommended is that hematocrits maintained greater than 30%, hemoglobin greater than 10, in the presence of hypoperfusion for the first 6 hours. That's not based on very good data. After that, hemoglobin, as long as they're stable, using a trigger of 7 grams per deciliter. And that there is a lot of good data, both in the trauma world and the critical care world and the combination thereof, to suggest that a hemoglobin of 7 outcomes are better, decreased complications than trying to keep their hemoglobin above 10. Increased mortality, blood's an immunosuppressant, those types of things. So they randomized 998 patients. Keep in mind that in this study, 40% underwent emergency surgery, so this does apply to our population. And they were randomly assigned to receive 1 unit of blood for a hemoglobin of 7 or less, or 1 unit for a hemoglobin of 9, and maintained between 7 and 9 and 9 and 10. And what they found, again, was that the 90-day mortality, ischemic events like strokes and heart attacks, and the use of mechanical ventilation and life support was all similar. The nice thing, which we are all know and understand, is that less transfusions were within the hemoglobin 7 group. So this is just more data to support the fact that a hemoglobin of 10 is not really supported in the literature for numerous patient populations. And so hemoglobin of 7 appears to be where things are going to end up. Published just a couple weeks ago, a trial of the route of early enteral nutrition or nutritional support in critically ill adults. We all firmly believe that the enteral route is the preferred route. It's not based on very good data, though, mostly meta-analyses, and I didn't really know that until I was trying to review for this stuff. But they compared early enteral nutrition versus parenteral. We all know TPN is bad. We're forced in at times, usually about day 7, to start a parenteral nutrition, but this study challenged that. 2,400 patients were randomized to parenteral and enteral nutrition. Nutrition was started within 24 to 36 hours, mostly at the 24-hour mark of admission to the intensive care unit. Target goals were supposed to be achieved within 48 to 72 hours. Reasonable request, reasonable to ascertain, to get to. The primary outcome of 30-day mortality was actually similar, as were all these secondary outcomes. And in fact, between both groups, the majority of patients did not meet their goals within the 48 to 72 hours. So this paper truly challenges the notion that TPN is bad. This is a very well done study. I didn't see that many of these patients were surgery. I couldn't tell based on looking at the paper, but does it change my impression of TPN? No, but it probably should. I still think, and I think many of us think, that the gut is still the best route to deliver, but this certainly challenges that. Another paper just published in JAMA within this past year. I'm sorry that some of this is cut off, but they looked at high-protein enteral nutrition enriched with immune-modulating nutrients, so immunomodulating nutrients like glutamine, antioxidants, omega-3 fatty acids, has actually in the past been shown to reduce infections and enhance recovery from critical illness. When you look at the ASPEN guidelines and the Society of Critical Care Medicine, it's a grade A recommendation in SICU patients. It's grade B for the MICU, which is how it should be. No, it's so grade A for the SICU. 301 mechanically ventilated patients randomized to high-protein enteral nutrition with immunomodulating agents. I think everything in there but the selenium versus just high protein. Just keep in mind that, remember, high protein targets have been shown to reduce mortality. And so these patients were randomized within 48 hours of admission. Their primary outcome was infections. We know infections are bad. And it was similar. And this also evaluated patients who were trauma surgery patients, surgical patients, and medical patients. No increased incidence of infections. There was a higher 6-month mortality in the medical patients and in those who were greater than 80 years old on post hoc. So again, remember, study's not powered for this, but it was quite interesting. When you combine this study with redox and signet and omega, it appears that the days of immunonutrition are over. So 4 very well done studies. Keep that in mind. So Dr. Nathans took my fire with respect to the timing of tracheostomy and TBI, and this was one study that he went over using the TQIP data, and this is the exact same study. Just briefly, 1,154 patients within the TQIP database, early trach less than or equal to 8 days or late greater than 8. And again, what they found, the primary endpoint of decreased vent days was in the early trach group. When you look at ventilator days, ICU length of stay, hospital length of stay, pneumonia, all less. So I think we all in our minds know that early trach is better for these patients from a hygiene standpoint, from a VAP standpoint. It's difficult to prove. This is a cohort-matched, propensity-matched study, so these are evenly matched patients. Some pretty in-depth statistics, which I don't even pretend to understand, but it sheds a little bit more light on when we should be traching these patients, probably within the 5 to 6 day range. Blunt cerebral vascular injury screening. This was presented in 2013, published recently in the Journal of Trauma. Blunt cerebral vascular injuries portend a high mortality and morbidity when they're unrecognized and therefore untreated. The Memphis group, Denver group, even the Tyler, Texas group have all looked at these injuries and have published a lot on the 32-channel multi-detector CTA. There's a lot of data published on that. There's really none on the 64-slice scanner, and so Dr. Croce's group and Dr. Fabian recently published their experience looking at the 64-slice scanner. The nice thing about this study, and the reason that I'm presenting it, it's not randomized, but every one of these nearly 600 patients also underwent formal angiography. That is a huge undertaking, but it is the standard of care to get the DSA. With the 32-channel scanner, sensitivity is only about 51%. Depending on which paper, it's as low as 41 and as high as 98%. 98% you got to be a little leery of. When they looked at the 64-slice scanner, their sensitivity improved to 68% and their specificity 92%. They did miss about 62% of the injuries that were missed were low grade, no strokes. The authors noted that the complications, the cost, and the resource demands getting an angio suggest that the 64-slice scanner is now really should be the standard of care for diagnosing a blunt cerebral vascular injury. Also, interestingly, in Memphis, they have such a high false positive rate that every patient with a positive CTA goes on to get an angio. Who in the group is doing that? Because I can tell you I wasn't trained to do that. We don't do that at Chandler. West Valley? So nobody really is doing the angio to confirm an injury. In Memphis, they have such a high false positive rate, and maybe we do too, we just don't know it, that every one of them go on to get formalized confirmatory angio and again, you don't want to overtreat a patient, especially if they're TBI, they're at risk for bleeding. You don't want to overtreat them if they don't have a true injury. So I found that to be quite interesting. But this is a great study. This is a very well done study. And thanks to Dr. Ball, I was texting him last night going, Chad, I need more studies on trauma. And he says, hey, Del, why don't you do this one? So this was actually a very good study that he did with his South African colleagues looking at sternotomy or drainage for hemopericardium after penetrating trauma. The standard practice, as you know, is to split these patients' chests and go in and repair, evaluate, look for whatever the source is. In Cape Town, their experience has been that nearly 70% of the time in this small pilot study, there's nothing to fix. And so they challenged the notion of mandatory sternotomy for these patients. They randomized 55 patients to sternotomy, 56 to pericardial drainage with a washout, meaning they just irrigate it, and if blood came back, they were open in the chest after a subxiphoid window. 93% in the sternotomy group didn't have a cardiac injury, or there was a tangential injury that nothing was to be done. 4 patients with endocardial wounds had all sealed. There was 1 death, oddly enough, in the sternotomy group. So there was no increase in mortality, and in fact, there was shorter ICU and hospital length of stays. So something to very seriously consider. We are not, it's certainly in Arizona, a high penetrating cardiac injury. We don't see a ton of those, so I suspect most of us still feel comfortable going after that. Plus, we need to operate ever so often too. So anyway, this challenges the dogma of mandatory sternotomy and something to consider, definitely. So I think that's the end of my slides, and thank you again.